that is anterior posterior spread. So when you decide for an RP4, we can apply the same rule. The first is there has to be no cantilever, remember. And if there are 3 continuous contacts, always make it pi. There should be no 3 continuous contacts. You can make another implant in between. That's most important. In the anterior law, you have to really use it for the implants. The only exception to the rule is that when you're replacing the lower anteriors, you can place 2 canine implants and you can replace 4 anteriors. If you have to replace 4 upper maxillary incisors, you will have to do 2 in canines and 1 in the center. I don't want 4 continuous contacts. And that's a rule applicable everywhere. Sometimes I find the implant coming out in the canine region, distal implant, and 1 in the pterygoid. It will be sure short case of failure because you're going to have number of contacts will be more than 3. Okay, so plan that there are no 3 continuous contacts anywhere except the lower anterior, which is acceptable. Okay, no continuous 3 contacts. That's how the planning should be done. So number of factors goes into planning, whether it's the arch form, opposing dentition, bones available, bone densities, expectation. But the most 3 clinical important factors that we found is the age of the patient. Why is the age important? Because should I be doing a zygoma in about 40-year-old or 45-year-old or 50-year-old or 55-year-old? Maybe I can get away with bone grafting. I can do a sinus lift, I can do a bone graft, and I can manage. So age becomes a very critical factor. First of all, cost, which is the cost, because of the Indian scenario, the cost becomes a problem, and the clinician's ability. It's you're able to, most of the time I see nowadays implantologists, they will not do a sinus lift, but they will put a pterygoid and a zygoma. Right? They will not do a direct sinus lift, they will probably straight away go to zygoma, which is not, because plan B should be reserved for later. So given a choice, when a young implantologist, I will still prefer that you should learn bone grafting better, and then as the age, you see more failures, then you should opt for different bone zones. So patients like these, lip support. Now before planning any prosthesis, lip support also becomes. Patient will come to you and say, I just want teeth for function. But after 7 days, they will tell they're not looking nice because we didn't go into lip support. Patients like these, should you really do bone grafting or should you really do all on X? That is a good critical. If the patient is healthy, less than 60, I would still prefer to do a direct sinus lift rather than going into zygomatics and pterygoids. That's the criteria that we follow in our centers. Now, what is lip support? Lip support is very important. There are a lot of patients that will come in a class 3 situation where the vertical height of the bone is very good, but the horizontal height is less. So in those cases, if you try and place the implant, what happens is this lip sucks in. So it looks like the patient doesn't have teeth, he has elongated upper lip, and still he has fixed teeth. So the other option would have been to put a flange on the prosthetic, which is not correct. Because when you are doing an FP3 prosthesis, that is fixed prosthesis, there is no flange. Remember, you cannot clean these areas. Okay? So in these situations, if you do an all-on-4, this will look horrible in these cases. So if the lip length and there is no lip support here, then the all-on-4s are all useless. So when you have to do lip support in these areas, try to do a horizontal graft. That's a different thought process altogether. When you are planning to do all-on-4 in these cases, you have already taught to cut the bone. But sometimes you must re-evaluate what is the lip support. That is an area that you really need to graft. Okay? So case, I'll tell you a very simple case. This is the first case that people ask me, why did you do these things? But I'll show you a very simple thing. Look at the case. Tons of bone. Don't even bother about bone. I could do fixed prosthesis. This was practically 20 millimeters more. I think it was 28. This was also about 19 millimeters. I could place any number of implants anyway. But what I did was I only placed 6 implants. People say, what's the money? No, money was never. Patient was from Afghanistan, money was not a problem. They come with dollars. So that is not a problem. I only did 6 implants. He said, why did you do 6 implants? So I made a bar and clip, made 2 locators, and made dentures with a metal framework, They locked well. Good locators. Everything is great. Absolutely fantastic. I could never remove this lip support. If I had done a fixed prosthetic here, I could never support this lip, sagging lip, with a fixed prosthetic. So she would still look old. Now you look at the change in the face. So plan, when you take a patient, you have to first analyze the restorative space. Okay? The restorative space, what kind of prosthesis. Then you plan where the bone available. Now we have to scan the next step, how to really analyze the bone available. So lip support is the most important. People will come and say do fixed. No, do that. Lot of lip support. If I had done a fixed prosthesis, she would really look old without this. Okay? So that's the reason I chose to make the lens. Now radiographic assessment. These are old time things, but we'll simplest old thing I used to do many years back. Something like attach this thing, use this thing. Now what we do is we will make some temporary dentures at our center, and we will drill holes on the palatal surface of the upper anteriors, occlusal surface of the molars, similar on the lingual and the occlusion, and get a CBCT done or probably an OPG done, whatever. We really need to analyze the bone wherever there, because that's the simplest. Now what do you fill in those areas? Some people say put katta parcha, some people say, normally cavity, temporary material is rhodiopic. Okay? Put cavity is the simplest thing to do, and you can do it. Or the simplest way to duplicate, let's the patient is wearing a denture, you can duplicate denture in about 15-20 minutes in the office. How do you do is take a putty, invest the denture in it. Okay? Let the mold settle, then open the mold, put cold cure resin, and you will be ready with the denture in about 15 minutes. Simplest thing. Okay? If you want to start from the new one, you can actually use the patient. You can do a trine for the denture. Don't actualize it. You can use with the trine or make a temporary denture, or you can simply duplicate it. Then what I do is make holes in it, and the palatal surface of the upper anterior and probably the occlusal surface of the molars, and then get a CBCT done. Now, when I get a CBCT done, I will get the exact positions of my hole. But that doesn't end there. That denture would really be helpful. I would still use those holes and mark my areas on the mouth. There's something called indelible pencil that comes. You can really mark those areas in the mouth, and the denture doesn't finish there. What happens is, this is as simple workflow that I can get. Okay? The next step that I can still use this as a prosthetic shell. Now what I do, once I have marked, I start placing implants, and I can check whether it is getting in the right directions or not. So a simple denture made with cold cure can help you achieve so many things while placing an implant. You can really verify your positions even doing this thing. So that used to be a simple conventional method of making a surgical stent. This is the old method of surgical. It used to work fantastically even today. Okay? So the replicating a small denture and using as a prosthetic shell is the simplest thing that you can use. Prosthesis selection on the type of fixation. Now this is becoming this thing. So there are two types of prosthesis. Normally they are cement retained and they are screw retained. But what we have a new term is called SCRP, screw cement retained prosthetics, because of the changing abutment quality. Understand what is SCRPs? SCRP is done. Simplest SCRP is when you take an implant level impression, you send this dual abutment to the laboratory. The laboratory actually sends you the verification jig if you really want to do it. They will make the crown on it. They will actually cement the crown in the laboratory on this. Okay? And send you a prosthesis like this. It is actually cemented on this thing with an access node. That's called an SCRP. Now there are two ways to do it. You can get this crown, you can cement in mouth. Only thing is, don't torque the abutment completely, just keep the abutment, put the crown, cement it, and then remove it. So that the excess cement which will flow in these areas, you have to clean that first. Otherwise that will lead to peri-implantitis. The second option is the lab cements and sends it to you. And this is how it comes out on the mouth and the model. It's exactly the same. You will see in the model on the mouth, This is taught. There are only two problems in it. One, it is the SCRP. Also, we will discuss about the tie bases. They are same thing. Tie base and the dual abutments are all the same. There are two problems that are there. Remember, I cannot define the emergence profile. The emergence profile is actually inbuilt in the abutment. You understand? How does it come out is all inbuilt in the abutment. I do not change that. The difference between this and a custom abutment is this only. In a custom abutment, I can define my emergence profiles. Okay? These ones will not define, they are already predetermined. First. Second, the weakest link will be the cement. So some places that I find people using a small abutment, but the mesiodistal distance is too big. And it is only retaining on the cement. When the patient chews on left, right, there is a deep bond between the crown and the abutment. Because the weakest link is the cement. Third problem, once I have received this, once I have received it from the laboratory, I do occlusal adjustment in the mouth, I cannot reglaze it. Because if I put it in the furnace, the cement will fly off. Okay? So I cannot reglaze it. Sorry, I'm just Just give me 1 second, please. Sorry. So there are three problems that we've seen. That emergence profile is not defined. The second is the cement. Big crown, small this thing will be a problem. So in a big mesiodistal crown, it's better to make a custom abutment than to use a dual abutment. Okay? That is second thing. And the third thing is we cannot reglaze the surface here. You have to polish in the mouth and fix it. Okay? Three things. But still 90% of time you can get away with it because making a custom abutment is not cost effective. Okay? Custom abutments can be made with two things. One, castable, which is UCLA. Remember? UCLA. Second, by milling, it's called a pre-mill abutment. So custom abutments can be pre-milled. There are pre-mill block that comes. They can mill and make a custom abutment for you. Second, if you want to go for a cheaper version, it's called by casting. It's called UCLA. To counteract those problems, these abutments were introduced. Something like tie base or dual abutment. They are same thing. Just names to confuse you. Okay? The industry was mostly into casting earlier. We didn't have milling units. So casting, the UCLA, University of California, Los Angeles, what they want to define, make that abutment, where the base was chrome cobalt and the sleeve was plastic. Okay? That is why they wanted to do casting methods. Now the casting is going away. The company is providing pre-mill blocks, means the connection is titanium. Okay? And they mill the abutment to make the custom abutment. So I'll show you a case in the other ones where we use the custom and the one. There is no difference. Only difference is the emergence profile. I have to control the gingival forms. Okay, I'll show you what happens with the other. So it's the simplest method to do it. So prosthesis based on the level of fixation. You have to understand what are the prosthesis based on the level of fixation. They are cement retained and screw retained. Now cement retained can be at the implant level, that is like this. I do not use cement retained now. We used to use a lot of cement retained, but now we have mostly the screw retained that is coming. The screw retained, madam, could you forget about, just listen to it. Busy recording, listen, stays in your mind. Yes, I am talking to you, madam. Use hair. Okay? It's better to learn. It's years of hard work for us. No? When you will do years of hard work, you can be a podium speaker and you can do that. Okay? Do that. The boss, my boss was the director of, you know Hari Prakash? He just passed away 2 weeks back. He was my boss. I was his second PG. So I'm talking in 96. Okay? It takes me a lot of hard work and I really feel sad for it. So you should get an opportunity to, I'm teaching you, that's more than enough. Okay? So screw retained prosthetics. Screw retained prosthetics can be of two types. One can be an implant level and the other will be at the apartment level where we use multi-units. So implant level and the multi-unit, that's the multi-unit apartments. So where do we use what? People nowadays are too much into multi-units. Suddenly there is a shift towards multi-unit. I want to use multi-unit everywhere. No, I'm not looking at it. Okay? When you use implant levels is when you have a limited restorative space. The idea is when the patient is a Bruxer, they have limited spaces. Then I'm going to use an implant level impression. When the aesthetic zones, typically in the front ones, I cannot use multi-units because the recession will happen and the multi-units collars will show. Okay, that's an area that I'm going. Jahan pe transition, when I smile, I show my lip lines. That I'm using implant level impression because I want highly aesthetic areas to work. To make them parallel. On the other hand, what are the indications of multi-units? When you have restorative space, that's most important. When you have hybrid prosthetics, that means I'm making two prostheses with different, hybrid means FP3 prosthesis. So I want to keep my implants above the gum levels. Thin tissue biotypes, people who have very thin tissue, I don't want to open my multi-units, don't want to open my implants again and again and disturb the biological width. I don't want to touch those areas. Full arch tissue level prosthetics, full arch prosthetics, where we have a tissue level implants where can be used. That is the area that we have to do. Okay? Immediate loading. Now that's another criteria that we follow these days. A lot of rush. People the micro motion of the implant is the problem. So if you have the micro motion limit within the 50 and the 150 microns, then the implant is going to be stable. If the movement is way higher, then we are not going to have a good, we're going to have a failure of the implant. So remember, when you place an implant, the primary stability is dipping and the secondary stability is rising. Now this area is practically between the first and the fifth week. That's an area that we have a problem. Okay? So, and after that the secondary stability. So the critical time is between the first week and the fifth week. So if you have to do an immediate loading, the implant is the most vulnerable between the first and the fifth week because the primary stability is reducing and the secondary stability is rising. So the golden rule is that if you can load the prosthesis within the first 3 days, that's the best thing. Or you at least wait for 6 weeks. Okay? That's the first thing. Also, the arch has to be rigidly splinted. Rigidly means the prosthesis should be rigid, not movable, only acrylic. Because that's an area where the fracture will happen. Where the temporary abutments are there, temporary cylinders are there. That's an area. Remember, immediate loading is normally cross arch, means the whole arch is loaded. Some people will post that I did a unilateral section of immediate loading. That is not acceptable today. Because what happens, centric load is going to be fine, but when you have an eccentric movement like this, they're going to fail. So immediate loading is only for full arch prosthesis, not for sectional. They will post, but they will not show failures. Okay? I see people doing one pterygoid, one zygoma, one transnasalis and only doing 3%. No, not correct. Okay? So just go cross arch. That's most important. Short implants. Now short implants is also another area of coming up very, I think people don't want to do sinus lifts anymore. They want to use short implants. The nerve is higher. They want to place them. My experience of short implants is basically I split the prosthetics. I still am not able to do individual crowns and all of them. So my take, well, I still am not very confident doing individual this thing. Cantilevers. Now how much cantilevers is available? Cantilevers in maxilla should be less as compared to cantilevers in the mandible. What is the acceptable limit? Is actually 15 millimeters in mandible and is actually 12 millimeters in the maxilla. That is the acceptable limit. Now what is 12 millimeters in mesodistal width? Probably a molar in maxilla and probably a premolar and a molar in mandible. That's all cantilevers I'm looking at. And remember, whenever you have cantilever, you have to keep this area in infraclusion by 100 microns. That means my red and the blue 100 micron paper, when a patient bites, in the centric position, it should not touch. That's as simple as that. How many use blue and the red papers? Do you use? Everybody uses? What's the thickness of shim stock? Shim stock. What? Shim stock. 20 microns. What's the thickness of the red paper and the red, yellow, blue paper? Wash. It comes in wide variety. It comes up to 200 microns. Okay? So you normally use 40 or 20, which one you use? 40 microns. Shim stock is 20. Claire, any questions? I personally, the study was done in 2016 by Hiroshi in Japan. He said provisionals avoid cantilevers. As simple as that. If you want long-term provisional prosthesis, don't bother about cantilevers. Because cantilever loading will already put the maximum load on the distal implant, which is eventually going to lead to problems. What's the reason? I'm sure. That's the reason. The primary stability will dip. What is stability? When you measure top values, that is one thing, and one is called the ostal values, that is there. That is the two things that you have to really see. The bone implant contact ratio and the torque. People only think of torque as the volume. The measurement of the RFA values, what we call it, radio frequency analyzer values, should be about 79 minimum when you check it. So if you ask me today, will I have, there is going to be a situation where the torque value, let's say 50 Newton centimeter square, but if you do a RFA value, that is going to be only 10. You can have situations like these, yes. When you place an implant, the torque was because of the cortical bone engagement, but there was a lot of space around the implant. Okay, the RFA values will be ISQ values, what do you call it? ISQ values will be way less, but the torque will be way higher. Should I load the implant? I will not do that. The reason, I have to compare that my torque values and the ISQ values as should be in a healthy period. If I have a torque of 35, but my ISQ is 79, I'm happy. Okay? On the other hand, I can have high ISQ values, but the torque value will be way less. When do I have it those? Let's do I do a sinus lift, a direct sinus lift, and I put my implant. My torque, my ISQ value will be 80. If you measure, my ISQ value will be 80, but the insertion torque was only 50. Should I load those cases? Never. So what two factors that today most of the clinicians recommend is that you should analyze two values. One is the ISQ values and one is the torque value. So when you have placed an implant, the primary stability actually starts to reduce. So when you find a high torque value initially, it will eventually lead to osteoclastic activity and new osteoblasts will form. Now during that period, that is between the first week and the fifth week, the primary stability will go down. So if you really check the torque at the first day and you check the torque at the maybe of 3 weeks, you can spin the implant. So the primary stability is reducing, but on the other hand, new osteoblastic activity will increase the secondary torque values. Okay, so that's an area where critical. Those are the low lip lines. That means at about 21 to 29 days, if I ask me, the implant is the weakest. So the big question is, let's say I have made a full arch prosthesis or a temporary prosthesis and the prosthesis fracture on the 28th day, what will you do? मुंह के अंदर prosthesis टूट गया 28वें दिन, अब क्या करोगे? Will you open up the implants? तीन काम हो सकते हैं, या तो उसे नेसोगैस्ट्रिक फीड पे डाल दो, एनजी फीड, पेट पे डालो एक ट्यूब, क्या करेंगे? If the prosthesis is fractured on the 28th, then will you do? Will you open up the prosthesis? आपने इमीडिएट लोडिंग का एक प्रोसेसर दिया, आपने टेम्परेरी बना के दिया उसे फुल आर्च का, और वो क्रैक कर गया मुंह के अंदर, मे बी 25th day or 26th day. What will you do? If you leave it like that, the prosthesis will move and the implants will fail. Okay? If you open up, the implants will also come out with it. Because primary stability is down and the secondary stability is still not picked up. What will you do? Keep him on liquid diet? क्या करेंगे? तो उसे मुंह में नहीं ठीक करना, उसे खोलना नहीं. Okay? Try to be on a soft diet, but repair it in mouth. Okay? Don't open up, because the implants will also come out sometimes with it. Okay? So that's the most important aspect. So when I tell them to check for immediate loading, then I'm checking at ISQ as well as torque values as well. Questions? I would love to go for implant because most of the yes, because recession will always happen. Also, the emergence profile in the multi-unit. Wait, difficult to go back. No? Remember, the emergence profile of the multi-unit is not customized. It is sometimes bigger. People don't know what dimension of multi-unit to be used. They come in 3 diameters of 3.5, 4.5 and 5.5. People do the biggest mistake of using 5.5, which is not advised. They should use only 3.5 because more the force on the tissue will recede. What is the 2 responses in a body? If there is a threat to you, what will you do? कल आपको कोई मारने आएगा, आप क्या करोगे? You either fight or take a flight. So tissue fights initially, then it gives away. It says sorry, I'm going to leave it. So this golden area starts showing up. So if the patient has a high smile lip line and he's smiling, the golden areas will show up. So that is the reason that we use implant level impression in high aesthetic zones. So full arch cases are not high aesthetic because there is already resorption and the transition line is way up. ठीक है, तभी ऑल ऑन 4 जब हम करते हैं तो हम बोन को थोड़ा सा हाइड करते हैं, चिप करते हैं, क्योंकि I have to hide my transition lines. Clear? Question? Good. He's not sleeping. Okay, so full arch restorations are simply, the solution can be simplest as an RP5 prosthetics. You can have, this is a good question, I always ask. Which of them is incorrect? Which of them is incorrect? A, B, C and D. Which one is incorrect? Which one? B? Okay. Huh? Which one is incorrect? B. This is okay? This is our answer or not okay? This one is okay? This one? So let's say how many say A? ये ठीक है? Correct? This one? So 3 people find it wrong. Okay, 4, 5, 6. This one? 2 people find it wrong. Wow. This one? Okay, I ask a simple question today. Very simple. अपने मुंह में एक कैप चढ़वा दी लोअर 6 में, फर्स्ट मोलर रूट कैनाल कराया था, कैप चढ़ा दी. किसकी चढ़ाएंगे? हाँ जी, किसकी? मैं 5 चॉइस देता हूं, बताना कौन सी चढ़ानी. जरकोनिया वाले हाथ खड़ा कर ले. जरकोनिया में लेड चढ़ाओगे या मोनोलिथिक चढ़ाओगे? हाँ जी, लेड और मोनोलिथिक. हाँ जी, नहीं चढ़ानी जरकोनिया, कैंसिल हो. दूसरा ईमैक्स चढ़ाना, ईमैक्स वो भी नहीं चढ़ानी. क्यों? अच्छी नहीं है. हाँ जी, ईमैक्स में 2 फॉर्म आते हैं, प्रेसेबल ईमैक्स, दूसरा कार्ड ईमैक्स. कौन से चढ़ाएंगे? अच्छा, वो भी नहीं चढ़ानी. पीएफएम, पीएफएम समय चढ़ानी. पीएफएम में कौन सा चढ़ाओगे? गोल्ड सिरामिक चढ़ाओगे, सिल्वर प्लैटिनम सिरामिक चढ़ाओगे या क्रोम कोबाल्ट सिरामिक चढ़ाओगे? निकल क्रोम, क्रोम कोबाल्ट या निकल क्रोम? हाँ जी, कौन सा चढ़ाओगे? फुल मेटल का किसी को नहीं चढ़ाना, गोल्ड का, सिल्वर प्लैटिनम कॉम्बिनेशन नहीं, वो नहीं चढ़ाना. तो सबको पीएफ में चढ़ा दें. राइट रॉन्ग? जरकोनिया में चढ़ाना किसी ने? तो दुनिया भर की चीजें बेचते रहते. अपने मुंह में क्या करना है ये तो पता नहीं. राइट रॉन्ग? कैसी पढ़ाई करते हो? अपने मुंह में क्या चढ़ाना है? Where the cost is not important, the material is not important, you can get anything you want, and you are not clear what I will get it in my mouth. पेशेंट में कैसे डिसाइड करोगे इतनी सारी चीजें? क्लास 2 फिलिंग कौन सी वाली कराओगे अपने मुंह में? इनले बनवाओगे, कंपोजिट कराओगे, सिल्वर फिलिंग कराओगे? कौन से वाला कंपोजिट कराओगे? जी, नैनो हाइब्रिड या बल्क फिल? कौन सा कराओगे? नैनो हाइब्रिड अंदर डालोगे बाहर, वो पॉलिश के लिए अच्छा होता है, बल्क फिल स्ट्रेंथ के लिए अच्छा होता है. कौन सा डालोगे? क्लास 2 फिलिंग है मोलर, पहले बल्क फिल हो गया. So the idea is that you have to be clear in the thought process. What do you want? Given a choice of today's ceramics, I will use anything which is milled, because the accuracy is going to be way higher then a castable prosthesis. Okay? The abrasion resistance of Emax CAD is going to be similar to what my natural dentition is. I will still do an Emax lithium dialysis if you get down on my motor. They are strong enough and they will not have a problem. Given a choice, if I can mill a gold crown with a ceramic, I will still do that. Okay? तो अपने मुंह में क्या होना चाहिए ये तो पता होना चाहिए. जरकोनिया किसने लगाना था? मोनोलिथिक या लेड? मोनोलिथिक. वाह. कौन सा गलत है इसमें से? ये तीनों गलत है. इसमें से कोई भी ठीक नहीं है. सिर्फ एक का छोड़ो. Why? The whole purpose of locator is retention. This will generate resistance. Maxilla, you don't want retention. This one will create resistance. So you need to splint maxillary prosthetics. Splint and make a bar and clip. This one, again, the resistance increases. There will be a lot of problems. So splint. If you are doing more number of implants, make RP4, splint them together. Okay? The criteria is as simple as that. Oh, this is okay. That was only to show you that we can never do fixed prosthetics because of the lack of the lip support. This is the simplest thing that I always design. So in maxilla, I like to splint. As I go down, these are danger areas. I don't want to do those. If good, that means split or to separate, this is also okay. As I go down, mandible, because of the rotation forces, then the problem starts to happen. So these are not good. Clear? Okay? So full arch, all on 4, all on 6, or all on 8. The idea is, what are the position of the implants? In the mandible, you can do a split prosthesis. That means I can split my prosthesis into 3 parts, which is going to be 2, 3, 4 and 6. Means I place 2 implants in the 3 region and 4 and 2, 4, 6. If I'm doing all of the tooth positions. Clear? Procedures for severely resolved teeth, then they come in the all-on-4 concepts. That's how. And remember, in all-on-4, the screw axis opening of the abutment, the distal multi-unit, has to be most distal. You cannot have this screw placing in this direction. Okay? Why? Because I want to increase my AP spread. So let's do clinical part sometime. We'll just show you what we used to do earlier. The simplest mooring attachments, denture. How many of you make rugays? In prosthetics, rugays, prosthetist. You know, आपको आते नहीं बनाने? बना सकते हो? कैसे बनाते हैं? नहीं आते? Of course, there will be standard rugay platform you can record. Right? On the palette, yes, you should do that. Why don't you make rugays? Anyway, so locators is you can manage, and I can convert into nearly about 30 degrees of non-parallelism I can manage with a locator today. Okay? As compared to mooring, the height is high. It's always troubling the tongue. When the patient is not wearing a denture, the tongue actually has ulcers sometimes there. That can be fine. Also, whenever you reline the denture, whenever you have to change the housing for the locator, you have to change. Remember you have to reline the denture. You are changing the housing But if you don't reline the denture, the fitting is not going to be the same. So whenever you change the housing for the locator in about a year and a half, you must reline the denture as well. Okay? Cardinal rule. Anyway, all on eights, we used to do a lot of this. This is something old cases. Maybe I did this case in 2010. Yeah, used to straight bag implants. This is me when I was really young. Okay? There were different implantation techniques available that time, and being a prosthodontist, I always used to believe this is the how many of you use semi? Always used to make the copings and used to split them, not sprint them, because that was my thought process that when you do a full mouth rehab, you should not splint everything, you should split it everywhere. As a prosthodontist, they always do separate crowns rather than joining crowns. Because of, why do you separate crowns? Why do you separate crowns? हम अलग अलग क्यों करते हैं? Just to prevent the papilla, maintain better emergence from white and high teeth. I can floss it. Okay? So I used to do those, fix the teeth. Now this is after 9 years of follow-up. I made a new process. I removed everything and made a split. Because in maxilla, the problem is they were debonding and screw loosening was very common. So after 9 years, again I had to redo the prosthesis. And I just see a little recession here. Otherwise, the arch was doing fantastic. Now the patient is still living. He's 87. We've done more implants now. Here also we've done it, but he's still living. Okay. Similar case. Resolved. This is where I use a lot of probability implants. I think it's 2012. So we used to do a lot of probability implants. And screw rotate prosthesis, I think it's a hybrid prosthesis that we made. Patient is doing okay, I think it's pretty okay. Okay. Another case, this was a patient who told me that the bridge has lasted 25 years. This is 2012 again. That's the first time when the zirconia, layered zirconia came in. So, the best way to make the prosthesis last is how? 25 साल कैसे चलेंगी चीजें? उसके नीचे के दांत हटा दो. Don't put below it. Okay? It's going to last for years and years. Don't worry about it. Anyway, so some common medies I can see that. Some ones again I don't know what many implants. I forgot. Sorry. I forgot how many. This is the first time I did layered zirconia prosthetics. This was the combined in the arch, and the patient is still okay and doing well. It's been almost 13 years now. So the first hybrid is again 12,000. We did implants, and this was the titanium milled framework. You can see the milled framework, and it was relined by acrylic to reduce the weight because the distance was 15 to 18 millimeters, and I wanted to do a screw rotate prosthetics. And I milled the titanium bar, and over that I had this is the, I always tell this, if you can't give me this, you're of no use for me. And mere kisi kaam ki nahi. Okay? So that's what I'm always calling people to do it. That's a screw rotated prosthesis. That's how he was okay. And the patient is, I think, is passed off. Another full mouth. Now this is a case that has been still working. We did the first time when he was 62, now almost 10 years, 72, but we had failure. You must understand what went wrong here. The same case, other company implants made a screw rotate this thing, the access opening was here. Okay? Prosthetic, and eventually this thing, it is pretty okay, doing well. And he was opposing a denture. I was very confident it will never do anything. Opposing a denture. Unfortunately, the patient was always a Brooks, and I didn't realize that. And it looks nice. And people nowadays, they do something and they straight away post. I never post because I don't believe in it. Because this is not follow-up. Okay? They will immediately post, which I find a lot of people doing stupid. So I don't post. You can always post that. But this was after 9 years, the screw fractured and the implant failed. And then there was a problem because there was always a pain. This was the screw fracture that happened after almost 10 years of this thing, and I always thought that opposing nature will nothing happen go wrong. But then I had to remove that implant and do a nerve lateralization because the bone was really less on these areas. We did a nerve lateralization, and after 9 months he had a lot of paresthesia. We finally could achieve something like this. Now the new prosthesis, again a milled titanium part with prosthesis that is screw retained. You can see that. So we still have been able to maintain the vertical and doing it. So 10 years of follow-up, that was first thing, the nerve lateralization, and again we could do the same things. So once a patient gets implants, he will be there, then your wife will be there. Okay? Remember, he will be your son, he is going to be your daughter, your wife, everything is going to be there. So failing to plan is planning to fail. This is where I started learning what all-on-4 is and where I started the first big mistake. 2013 was the first time that I went to Marlowe's clinic, and as soon as I came back, I placed 4 implants. I didn't have the courage to load it immediately because I have never seen those things. And I made the prosthesis straight away after 4 months, 5 months I think. This is the titanium milled framework again, which is to reduce the weight, and beautiful prosthetic, fixed the teeth, and it was doing wonderful. In 6 months, everything came out. 6 months. That time I charged 4.5 lakh rupees, 2013. And 6 months, everything came out. And the guy used to sit in my operatory every day, see karna kya hai. So then you have to really go back to the drawing board and you really have to see what was the problem. The problem was this. It was a class 3 relation. And we actually made the teeth in class 1 relation. So what happened is the anterior cantilever was too much. Okay? And it would eventually, also the AP spread was not correct. That is the time that I started really working on the full arch cases better. So the ideal option could have been an RP4 prosthetic rather than a fixed prosthetic. So whenever you have a class 3 situation opposing a natural dentition, class 3 situation opposing a natural dentition is always a caution. It's better to refer, not to do the cases. Class 3 will always end up with a very long anterior cantilever, which will eventually trouble you in the long run. So treatment planning, when you have an edentulous patient, you can do all on 8 if you have good bones. You can do all on 7 with 2 cantilevers also, no problem. You can do all on 6. You can do all on 4s. You can still do all on 4s. And you can also do all on 32. Basal implants. You can put 32 implants, I don't mind it. I don't do it. You can do it. The most important factor that we find is the bone and the bite. What is the jaw relation? The 2 most important factors. If you have good bone and a good jaw relation, you will never fail. Okay? Remember, you should have a patient-centered treatment protocol. Do it all on 4. Don't get up in the morning and I'll do what is happening in the industry just for the Facebook. Okay? If you fail to plan, you will always plan to fail. Clear? Questions?
Sir, what are the problems that patients will face if they face all and four implants in the factory classes?
They will all fail.
Is it like
Anterior cantilever.
it's a fracture of the prosthesis or
fracture about the implants will start moving very soon. Because every time you do a class 1 relation, you do a class setup in class 3, you are what field? You specialist in some field? You are specialist on the field now. Specialist in every field. Jack of all trades, master of none. They are master of none, you are jack of all trades. No? Right or wrong? So class 3 situations, the problem is the anterior cantilever is going to be too much. So whenever the patient comes, and you always do a setup in a class 1, the reason is you want a good lip support. If you do a class 3 setup, the lip will be like banana, long, not so the teeth. So you always have a class 3 situation. So what class 3 relationship normally happens in the mandible, and the mandible is elongated, and to compensate the maxillary is just edge to edge or just half a millimeter forward, right? So as you lose the teeth, because the teeth are already so compromised, the resorption happens faster in the upper maxilla. But the mandible remains the maximum force in a class 3 is in the front teeth. So when you do a class 1 setup and there is a horizontal cantilever of maybe about 10 millimeters, all the implants will fail. If the force implants are here, the prosthesis is here, and the force is here, what will happen to these ones? They will all go. So this is what happened. First common sign, if you see within the first 3 months, is screw loosening, change the prosthesis. It's not designed for 30 to 35. The abutment screw is torqued to 35, the prosthetic screw is torqued to 15. So if you torque 15 and the screw loosening happens, you change the prosthetic immediately because the prosthetic design is not correct. Okay? Anterior cantilever will be 2 months. Any questions? Okay? हाँ जी क्या देख सकते हैं एंटीरियर वॉल ऑफ मैक्सिला देख सकते हैं कि मेंटल नर्व देख सकते हैं मेंटल नर्व अंदर आती है कि बाहर आती है इज गोइंग इन और गोइंग आउट मेंटल नर्व इज अ ट्रिब्यूटरी फ्रॉम व्हिच जी कैसे देखते हो कैसे देखते हो कैसी दिखती है भाई व्हाइट रेड नहीं दिखती होगी ब्लड होगा वहां पर कैसी दिखती है what is the area that what is this? It's a nerve. Sorcery. Yeah. Anatomy everybody clear? Gray's anatomy पढ़ी थी, Snell's anatomy पढ़ी थी। ये बीडी चौरसिया से बात हो रही है? अभी सब विश्राम कर रहे हैं। It's very difficult to do. You just oh. Anyway, so nerves are not freely rolling; they are always enwrapped in a tissue. अगर आपको white दिख रही है, तो आपने अपना काम कर दिया। इसका मतलब आप नर्व पे ही बैठे हो। क्या जी? It is always enwrapped in a tissue. Okay, so it looks like a slimy rope that is going out, but आप आगे से ना करें, आपने काम कर दिया अपना, उसे बंद करें और सो जाएं, ठीक है? So one is the mental nerve, and the other one is the anterior wall of maxillary sinus. Now, how do you really want to see this maxillary sinus? कैसे दिखेगा ये? Why do you want this one? Okay, so when you see an X-ray, the distal to the canine eminence is where the wall starts to drop. Whenever you open, this is the wall that starts to drop. Okay? When you open up the maxilla, when you open up the tissue, the only thing prominent, what are the three landmarks that you always going to see? क्या होते हैं वो? क्या landmark दिखते हैं? तो क्या देखेगा उसके अंदर? वो only देखना canine eminence, that is one sign, good. Anterior nasal spine दिखेगी? नहीं दिखती? And you're going to see the incisive papilla. जहाँ से नर्व बाहर आ रही होगी, बाहर आती है कि अंदर? बाहर ही आता है. Anyway, so distal to the canine eminence is where your sinus starts. So the best way to check is to make a small hole distal to the canine eminence. Put your excavator and mark a line from up to down. Now this will actually tell me where the sinus anterior wall of maxillary distal implants must engage this wall. Immediate loading, because this is a thick cortical bone. If I engage this thick cortical bone, my immediate loading implant will work. If I only engage the alveolar bone and the nasal floor, my immediate loading might not work, and also my AP spread will reduce. Okay? That's more important. That's one thing. Now, what are the other methods of checking it? The other method is to use a surgical guide. Means I will share my CBC data, DICOM data, as well as they will combine both the exocad and design the guide. Then they will print an STL file which will be in a guide form. That's another one. So that takes my expertise and expenditure. So I can actually see it myself, or I can rely on the third party for a surgical guide manufacture. There's another method of finding it. There's a thing called trans-illumination. You have caries detector pens which are available, which are trans-illuminated. If you really trans-illuminate the maxilla, you will find a thick bone which is radiopaque as compared to the other wall of maxillary sinus which is radiolucent, which is more translucent. So that's the area that you can always find the anterior wall of maxillary sinus. The most important criteria before starting an all-on-4 is to learn these two landmarks and identify them. If you can't identify them, don't do all-on-4. Okay? The anatomy of these two landmarks is of prime importance, because if so when I operate, I first have and I have to see the anterior wall of maxillary sinus. That's the most important factor. Okay? So general considerations, blah 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 blah. You just need about 35 to 45 Newton centimeters of primary torque. There's something called composite torque value, CTV. There's some people claim it should be 140, but that's not a correct study, because I need 35 in individual implants. If a composite torque value of 1, okay. More importantly, in the maxilla, it's more important to have the two distal implants. Remember, the two distal implants should always have a higher torque value than what you can have in the center. The minimum bone width which is required is 5, the height is 10, and it will be 8 millimeters in mandible. Splinting is paramount important, and for traditional implants, the access opening should not be more than in front of the second premolar. The second premolar or the first molar are the ideal positions for the distal. armamentarium required. Of course, the implants, they come in different sizes. Maybe about yellow, they're not color coded as per the. Every company uses a different color coding mechanism. It's not like rotary files, which everything is color coded. Remember, right? And the multi-units, which is most important to understand. The multi-units are two types. One are the straight multi-units, which is like this. Sorry. Remember, they only have a hole for the prosthetic screw. They are single piece. The driver for this one is separate. It is not available in the kit. So sometimes people start with all on board without knowing the driver for this implant. Okay, that is one thing. They come in different gingival heights and the width. The width normally available in most of the Korean systems is 4.5 and 5.5. Although other systems have width starting from 3.5. Okay? Most of the Korean systems have only two widths, 4.5 and 5.5, only best in 4.5. Also, there is a separate driver, remember, which is a motorized driver and a flat driver for a straight multi-unit. Gingival heights for front ones are normally into 1, 2, 3 and 4, and the tilted ones are normally into 1.5, 2.5, 3.5. It all depends just here and there. The angulated actually have 15 degrees of angle, and there is going to be a 30-degree multi-units. You still have the platform width, which will be 4.5 or 5.5, and the gingival height from here to here. Okay, so only three types of multi-units are available in the multi-put standard system. If you go for the zygomas and the pterygoid, the multi-units are available till 60 degrees. That means you will have 0, 17, 22, 30, 45, 52 and 60 also. But that is only for the Israel systems which use that, and they are also for the pterygoids and the zygomas and the prostheses. They have a different, although the multi-unit head is the same, it's just the angulations will keep changing. So when you see a multi-unit apartment, it's called many different names, called multi-unit apartment, cross-mucosal apartment, angle screw, they will just change names, they are only multi-units apartment. So what happens, they have to have two screws. One is the apartment screw which goes in and attaches to the implant. The other one is the prosthetic screw which brings the prosthesis. Okay, this is the standard apartment which you get at the implant apartment ratio. That's the standard apartment. This is the only screw which is smaller, only about 4 mm. Okay, how many threads are there in an apartment screw? This one, idea? No idea? सबने इम्प्लांट डाले? 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 ऊपर में काम किया? नहीं. क्या किया ऊपर? Hearing aid, my hearing aid is at no idea. The microphones? Your turn, please. Yeah. So what did you do? You place the implant?
Place the implant, call the patient after 3 months for rehab because it wasn't mandibular, but it was placed in the mandible. Implant level impression we delivered the
So screw का length कितना?
screw length and the number of threads.
Normally has 8 threads to 10 threads max. 8 is the normal things. Okay? Anyway, this is the slide that nobody will share. So this is very important, and if possible, click this because this is what is important. Now remember, when you have multi-unit, there are two angles involved. One is a 30-degree angle. Let's say this is a 30-degree multi-unit. There is another cone of 22 degrees. So if you really add all four, so it's 30 and 22, both these sides at 32 degree tilt, this actually comes out total to be 104. Means if you even place an implant at 50 degree angle, you will get away with 30 degree multi-unit. You will still be able to make a prosthesis. So they can accommodate 104 degrees of non-parallelism. That means each implant, even if it's tilted at 52 degrees, you can manage with a regular multi-unit. Okay? This is most important. So they try to confuse you. Yes, when you hear that. Okay? That's the most angulation that they don't discuss about this time. So after that you need impression copings, and you will need titanium cylinders and the comfort caps. And this is the case. I'm going to just. So this is a patient that walked in and chronic smoker. And what a CBCT, I told them to do an all-on-4, they just placed 4 implants. Very stupid. But the conventional method now I follow is of course this one. Made a dentures and wanted to check the transition lines. I would like to check my transition lines. Now this transition line was the zone, and remember, bone reduction should be 4 mm above the spine line. That's the high spine line. So I need to cut some bone, something on this part because I don't want to show my transition. Okay? X-ray, and this is how. I'm going to stop and I'm going to show you a video which will show in 20 minutes everything from start to finish. That's my operatory where I work. Autoclave or ETO. I have the facility, I have an ETO, retain oxide, gas, I can sterilize them better. And that's the same patient that I showed you. Now he's live, not on this slide. Okay? So I'll take my mark the midlines, mark the vertical dimensions. Now I really need to record the vertical dimension and keep it because I want to maintain the dimension, vertical dimensions. So use that and keep that record with you. Okay? So that it's easy. Otherwise, if you use calipers, I think they tend to reduce in size or something. The simplest way to check is they are putting in the dentist. And that is the time that I decided that it will require 4 mm of, as the transition zones, the 4 mm of reduction that was required. It started with the lower first, mid-crestal incisions, straight away splitting the flap mid-crestally and giving 2 releasing incisions. The first most important thing in the lower is to mark the mental nerve. You have to locate the mental nerve first. That's the horizontal releasing incision that we get. So that one, right? It's no more distance than the first molar. It is always still the first molar. I don't go beyond the first molar. The grades to be used is 15C, not 15. 15 as a broader tip. Here I only use 15C, and this is an old video, but I normally now use the round body scalpels. full thickness flux. How do you buy a periosteal is a very big question today. You really have to buy a good periosteal. And how do you buy it? I'll teach you how to buy a good periosteal as well. Because people just go and buy instruments without realizing what instruments they really need. You really need to love your instruments because I cannot change my periosteal. So a full thickness flap and the ridge is thin ridge. And that's the first thing that I mark. My blunt probe will enter the mental nerve. I can see as it is, right? I'll do it on this other side as well. My blunt probe will pass and I can see. Now this is better because recording in between. So now again same process, we mark with the pencil how much of osteotomy we have to do. Piezo surgery is my go-to device. You use piezo? Which company? Better luck? What better? Although it is easier to burn, but I get to, why do I have piezo surgery? I can accumulate my bone. I don't want to waste my bone today. Bone is again with the smoother it out, little fun. I always believe that the patient swallow it can go. The first is the two distal implants that the chew. Remember, full arches, you need to love blood. How does the blood smell? Have you tasted blood? Yummy flavor, no? You used to get 45 feet. Maxilla is good, then you do the upper two central, and you remember these two parietal flaps I've sutured, so they don't interfere in my surgery today. I can easily do that, and again the X-rays, and you will see the 4 implants very much in place. Long implants with the 2 distal 30 degrees multi-units and 2 just tightening them further. 2 central ones are straight multi-units. Okay. So they have to be topped 30 newton centimeters. 30 or 35. There's a way to suture it. Since you have an extra tissue, don't cut that suture. Don't waste that tissue. You can do is take the flap from the buccal side and cover it up and put a comfort cap on it. It pulls the tissue in place. The better way I'll show you the next step is to pull the tissue over the multi-unit, do a crunch like this, do a punch, small punch, then attach a comfort cap. Okay? Screaming. Noise. Okay? Small punch. We use 2.5. I use 2.5. Then I put it over and put my comfort cap. So it holds my tissue there, and then I can suture it easily without any problem. So that's the now see that attached. Okay. Then start doing the floss. It's always 1, 2, 3, and 4. Not 1 to 4. So you go 1, 2, 3, and 4. Then you use a cotton resin. Some people say I'll just use a scan body. Scan body is okay, but in the terms of blood, sometimes it doesn't pick up that way. I find scan bodies to be more useful the next day than on this thing. Since a conventional technique I want to teach first, scan body is easier. The 5 registration becomes a little normal. So that's a pattern resin just for the impression. You have to keep the resin away from the sutures. There has to have a gap. Otherwise, when you take the impression, the suture will pull out. Okay, that's checking the tray, checking putty, as well as the light body injected there. You take an impression and the impression comes out easily. That's an impression. You can see you will be a little bloody, that's okay. Okay, you just have to attach analogs and pour the models together. Putting the comfort tabs back, do the same process for the lower as well. In the meantime, what you can do is trim the little bit of bases and you can put a bite registration paste and do a pickup so that you know where is the access holes to be made in the denture for conversion. The best way to is to retain your retromolar pad area in the palate of the above so that the position of your denture doesn't change that much. Okay? That's bite registration paste, simple bite registration paste. And you can pick it up in the upper and you can mark those areas where the denture. Because remember, the positions will change once you open the flap. The only stable landmarks are the palate and the retromolar pad areas, which is going to remain the stable. Now you can send this to laboratory, they will start making holes where the pickup has to be made by the temporary cylinders. And in the meantime, I have to just adjust a little bit of the tray for the lower. Because my distal implant, a little distal, same procedure, same pattern resin. I can use old diamond burrs and use composite resin as well, but just a demonstration was happening, so I thought I'll show you the entire process. Let's take the impressions. Again, now we have poured the models attaching the analogs and the model, and the in-house technician, I have an in-house technician which will make the holes in between so as to pick up my temporary titanium cylinders and convert. Okay? So now I have attached 4 temporary titanium cylinders, but I will not do the pickup like this because if I inject material, it's going to lock in these sutures. So I take rubber dam. First I have to check them, they are free to move it and see the position. I take a rubber dam, cut it through and attach. Okay? And pack it with Teflon tape here. And then I seal it off. And then I use the Q resin on the protect board. This is just light body so that I can remove it easily and not. That's the Q resin pickup. We'll show you the Q resin injecting the denture to the lower one. Bring it, and now when I open it up, my cylinder will be. Now you can see the cylinders incorporated in the denture. Same thing in the lower. That's the Q resin, that's pink color resin. Now something called protect, or you can same light curing. Now I pick up the dentures, the patient is still the same. And now I send it and they will seat on the impression models because they have to reinforce the dentures. They will take at least 3 hours. You put a wire inside and re-acrylize it and finish up with the titanium cylinders. Just a 22 minutes video, done in 22 minutes. It took me almost 9 hours to finish, from start to finish on the same day. And that's the titanium screws, small prosthetic screws. That's the same day we're happening, same day we did the surgery, same everything we deliver on the same day. And just hand torque it, both of them. No torque, only hand torque. Just because we picked up them in mouth. So it's going to be more accurate. And then we check light occlusion, I want either or in the oral area.
Right now, there is a full arc solution, not individual solution. When you make an angular velocity, then the tooth will be. Okay? You have a resolved area and you have a single tooth that is developing. Now, the resorption we have. So, right now, when you remove, you have to really remove so that your base